Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Prasad Katta. Dr. Katta graduated from the University of Gulbarga, India. He completed his residency in medicine in Great Britain and obtained the degree of Member of Royal College of Physicians. He conducted his residency in internal medicine at the University of Medicine and Dentistry of New Jersey in 2002, and a fellowship in endocrinology from Charles R. Drew University at UCLA in 2004. Dr. Katta is board certified in internal medicine and endocrinology. His interests include diabetes, thyroid, and osteoporosis.
We are going to talk about thyroid disorders and what you need to know basically. So thyroid gland is the gland of the endocrine system. So I'll discuss in the next slide what is the endocrine system. It's situated in the front of the neck here, so between the clavicle bones. These are the two clavicle bones, and it's below the larynx, which is the voice box. So it has actually, if you look at anatomically, it has the right lobe. This is the right lobe. This is the left lobe. And this is the middle part is called the isthmus. What's the endocrine system? The endocrine system consists of the endocrine glands. Basically, they produce hormones directly into the bloodstream. They don't need any ducts to produce their hormones. They secrete directly into the bloodstream. So there are different endocrine glands. If you look at it here, the master gland is the pituitary gland. It produces like 5 or 6 different hormones. The pineal gland, which produces the melatonin. The thyroid gland, which is in the center of the neck here. The thymus gland actually is not that important. It does have some function up till in the adolescent age group, and after that it does not. It atrophies. You have the adrenal gland, which sits on top of the kidneys, which produce like 3 different kinds of hormones. You also have the pancreas, which produces insulin, and the ovaries in women, and the testicles in males. So this comprises of the endocrine system, and the thyroid gland is one of the major glands of the endocrine system. It produces hormones T4 and T3, which are the active thyroid hormones. They have effect on different organs of the human body. It has effect on the heart. It can affect the skin and the nails, the intestines, hair, brain, muscles, temperature regulation, sleep, metabolic rate, and also the bones. So if you look at it pretty much across the board, it affects a lot of different organs of the body. So it's very important for that reason. The topics we'll be discussing today are hyperthyroidism, which is high levels of thyroid hormones, pregnancy and hyperthyroidism, another condition called subclinical hyperthyroidism, where the labs are abnormal, but the patients don't have any clinical symptoms. We'll also be talking about hypothyroidism, which is low levels of thyroid hormones, and that's one of the most common conditions which I treat in my office pretty much day in and day out. Thyroid nodules, which is growth or enlargement of the thyroid, and if it is large enough, which is visible to even a common man's eye, then we call it a goiter. And also we'll be talking about thyroid cancer. The blood tests I'll may be mentioning during the talk are these. TSH, which is the thyroid stimulating hormone. I'll go a little bit more in detail in the next few slides. Free T4 and free T3, which are the active thyroid hormones. The total T4 or the total T3, which are again the hormones, but they are protein bound. They're not the active thyroid hormones itself, but they are protein bound. They're bound to proteins. But most often we'll be talking about the TSH, free T4, and the free T3. We also sometimes check for antibody tests. One of them is called the thyroid peroxidase antibody. The other one is the thyroid stimulating immunoglobulin. The first one is more commonly checked when you have hypothyroidism. Sometimes we also check in the initial stages of hyperthyroidism to find out what the cause is. The second one is usually checked when you have hyperthyroidism. And the thyroglobulin is the another protein which is actually produced by the thyroid gland itself, and that's checked mainly when in patients with thyroid cancer. We'll be talking about radiology tests like thyroid ultrasound and the radioactive scan to find out the activity of the thyroid gland. With respect to radioactive scan, it can be used for two different reasons. One is the treatment of hyperthyroidism and also the thyroid cancer. This is we call it the HPT axis. It stands for hypothalamic thyroid axis. Okay, so if you look at this here, this is the pituitary gland, and on top of the pituitary gland is the hypothalamus where my arrow is pointing there. So that actually sends signals to the pituitary gland to produce the TSH, which is the thyroid stimulating hormone. So the hypothalamus, which sits on top of the pituitary gland, sends signals to the pituitary gland through this hormone, which is called thyrotropic releasing hormone, to produce the TSH. The TSH, which is the thyroid stimulating hormone, in turn sends positive signals to the thyroid gland to produce the active thyroid hormones T4 and T3. So then the T4 and T3 are released into the bloodstream and they affect the different organs we spoke about earlier. So if we have enough hormones or enough hormone levels of T4 and T3 in the bloodstream, what they do is they send negative signals to the pituitary gland not to produce too much of the thyroid stimulating hormone. So basically it acts like a braking system. We call this usually a negative feedback loop. It's a very common terminology in like engineering, things like that. It's a negative feedback loop. So something which is positive, and then you have enough in your body, so that in turn sends negative signals to the pituitary gland not to produce too much of the thyroid stimulating hormone. And also the T4 and T3 act on the hypothalamus also not to produce enough of the thyrotropic releasing hormones, which is the TRH. So this is how the system works, the HPT axis works, and the system is kept in check. I'll just go over the HPT axis only in the normal patient here. This is the pituitary here. The TSH turns on the thyroid to produce the T4 and T3, and the T4 and T3 in turn turns off the signal to the pituitary gland to produce enough TSH so that they have enough T4 and T3. So in a normal patient, TSH is normal and the T4 also is normal. The next part of the talk, I'll be talking about hyperthyroidism itself. It's just generally a condition exposed to excessive thyroid hormones. About 1.2% of Americans are hyperthyroid, and this majority of the patients are actually subclinical. 0.7% is subclinical, so more than half is subclinical, and 0.5% is overt, that they have symptoms. They come to the physician, whether it's an endocrinologist or a primary care physician, they come to them with symptoms. Okay, I have this or I have that, and we'll talk about it in the next few slides, what symptoms they are. 5 to 10 times more common in women than in men. In the mildest form, they may not have any symptoms at all. It may be just lab values. And more often, patients have discomforting, disabling, and even life-threatening symptoms. So then they'll definitely be seeing their physician. So what are the symptoms? With respect to fast heart rate, so they may complain of what we call as palpitations. They can have nervousness, anxiety, irritable feeling, or quarrelsome feeling. So if any of the spouses are quarreling with their others, that's one of the things to check. I'm just kidding. So trembling hands, weight loss, even when eating more. One good thing to have if someone wants to lose weight, but again, for all the other things, it may be a bad thing to have. Increased sweating, intolerance to warm temperature. Even in a normal room, they'll feel that it's too hot. Muscle weakness, especially the upper arms and thighs. And sometimes I've seen patients present with weakness. These are patients who are 30, 35-year-olds, and because of loss of potassium, which sometimes can happen, they present with weakness. They can't even walk. They'll have to pretty much crawl. So that can also happen, but it's very rare. Loose, frequent bowel movements, thin and delicate skin, change in menstrual pattern, and usually the menstrual pattern change, they have less menstrual periods, means either they're missing periods or their periods are very light, and that's what usually happens. Prominent stare of eyes, protrusion of eyes with or without double vision. This is what happens in Graves' disease. We'll talk about that a little later. Eye symptoms, these usually can behave independently of the thyroid status, and important to keep the thyroid levels in the normal range. Irregular heart rhythm in older patients, and accelerated loss of calcium and bones, and there's also risk of osteoporosis and fracture. These are some of the things as we discuss: intolerance to heat. This lady is having a fan here, fine straight hair, bulging eyes. They also have facial flushing, enlarged thyroid. In most patients you do see that, and tachycardia is just that your heart rate is faster. Systolic blood pressure is increased. Usually only the upper blood pressure, there's two readings in blood pressure, the systolic and the diastolic. The systolic is the upper reading, and that's the one which is increased. The diastolic remains normal. Breast enlargement in men, and weight loss, muscle wasting we discussed. They can also have edema of lower limbs. That is the swelling of the lower limbs, they can have that. Finger clubbing, this is the increased curvature of the nails. That's one of the things. If it's really severe, they can also have that. Tremors, we discussed that. And diarrhea and menstrual changes, usually, as I said, they don't have menstrual cycles, or it's very mild periods. This slide, I just wanted to show you thyroid eye signs. And in this slide, this patient has this left eye, which is sort of more prominent. In both these patients, they have both the eyes which are sort of prominent, and they have actually severe eye disease compared to this patient, and this patient is somewhere in between. So again, as we discussed with respect to the blood tests in hyperthyroidism, the TSH stands for the thyroid stimulating hormone, is usually the screening test for most thyroid conditions, okay? And the test is usually low. If abnormal, the TSH is abnormal, it's followed by other tests like total T4, total T3, or free T4 and free T3. These are usually high. The thyroid antibodies, which I discussed earlier, is like the TSI and the TPO are also done to find out which condition is causing the hyperthyroidism. So we'll talk about it a little bit later. I'll go into each of the conditions causing hyperthyroidism. So this is again the HPT axis, which I just wanted to show you so that you're familiar with it. The hypothalamus secretes the TRH that sends positive signals to the pituitary gland, which secretes the TSH, and that sends positive signals to the thyroid gland, which secretes the T4 and T3. And in turn, if there is enough T4 and T3 in the bloodstream or in the body says, okay, that's enough. So they send negative signals to the pituitary gland and also the hypothalamus not to secrete the TSH and TRH respectively. So in hyperthyroidism, this is the HPT axis in the hyperthyroidism. So basically what's happening is there's too much thyroid hormones in the bloodstream, and it's sending negative signals to the pituitary gland not to secrete the TSH. So what happens is the TSH in hyperthyroidism usually is low, and the T4 or the free T4 and the free T3 are usually high. So that's what. So most of the times when we are getting the blood test, the TSH, we'll think, oh, TSH is low, so you have low thyroid. No, it's the opposite. If the TSH is low, you have excessive amounts of thyroid in your blood, that is hyperthyroidism. If you look at the reference ranges, the normal range of the TSH is 0.4 to 4.5, and in hyperthyroidism, it usually will be less than 0.4. And the free T4 is between 0.6 to 1.8 or 0.8 to 1.8 is usually greater than 1.8. And the free T3 is usually 1.4 to 4.2 is greater than 4.2. Blood tests in hyperthyroidism, usually we also check for thyroid stimulating immunoglobulins. These are basically antibodies which are produced by one's own body, asking the thyroid to make more thyroid hormone even though there is no need. Because the thyroid doesn't have control at that point of time, because if your body's own immune system is asking you to produce more, it's, even though if it's thinking that it has more thyroid hormone in the bloodstream, it is sending the signals back to the pituitary gland, don't produce any TSH. The TSH is saying, okay, that's fine, and means to the pituitary gland to not producing any TSH. The pituitary gland is saying, that's fine, I won't produce any, but the signal is coming from the immune system to produce more, and the thyroid has to agree with it. So that's what it's doing. So this is the thyroid stimulating immunoglobulins, we check for that. The TPO antibodies can also be positive if the hyperthyroidism is due to autoimmune thyroiditis. Sometimes the immune system sort of revs up and sends signals to the thyroid gland. Okay, so what that does is basically it destroys the thyroid gland and it releases a lot of hormones into the bloodstream, and that basically the TPO antibodies will be positive in that setting. Problem is, a lot of times when I see patients, both of these are positive. If both of these are positive, you can't really make a judgment call which one you have to go with. So then we go to the radioactive iodine scan. So that is the time we usually do it. If we can't make out which of them is positive. If one is positive and the other is negative, we can make a judgment call fairly confidently that, okay, this may be the problem, and we can tell the patients that. But if both of them are positive, then we have to tell the patients, okay, I really can't know what's going on, and we may have to do a scan, and we'll have to do the scan. So the radioactive iodine scan can be done with two different compounds. It can be the iodine 123 or iodine 131. More often, just for diagnostic purposes, we use the iodine 123. So how is the scan done? I'll just explain it briefly. Basically, you'll need to get an authorization depending upon the insurance. Medicare probably doesn't need any authorization. So then they'll tell you to go to the nuclear medicine, let's say nuclear medicine department in Washington Hospital. So then the Washington Hospital nuclear medicine department will tell the patient, okay, you can't eat anything 5 hours before you come in. You come in at 8 o'clock in the morning. So you go to the nuclear medicine department, they'll give you a pill. They'll make sure if it is in the childbearing age group, they'll make sure that someone is not pregnant too in women. And then they'll give you the I-123 dose, because this is a radioactive iodine. So we don't want any patients to be pregnant during that time. So you give this pill, it's a small pill, you swallow it, and then you come back after 5 hours. So when you come back at 5 hours, the 5-hour uptake is between 5 and 15 in normal patients. Anything above this is someone is hyperthyroid. And again, the normal uptake at 24 hours is between 10 and 30. Anything above the 30 range, the patient is hyperthyroid. So this is a normal scan. If you look at here, this is a normal scan. And look at this, this is in Graves' disease, how much more dark it is. So basically what they're doing is they are trying to find out a normal patient, and they're looking at the background activity of that patient, and then they scan the thyroid area and see what the activity is, and then they can figure out whether you are at 5 hours you are at 30% or 60% or 80%, then they'll tell you exactly. And they usually report it only after 24 hours. They won't give you a reading at 5 hours. They won't call us and say 5 hours is this, 24 hours is this. Usually they'll do both the scans and report it at 24 hours. As I said, conditions, I wanted to go each one in a little detail causing hyperthyroidism. Graves' disease. The disease is named after the Irish physician Robert Graves. It's not because the disease or condition is grave, but it can be if not treated. So it's actually named after a physician. It can be grave if it's not treated because of all the effects like palpitations, and that can lead to irregular heartbeat, that can lead to stroke, so on and so forth. As I said, patient's own immunity plays a role. It can run in families, and 30% of the patients have eye symptoms including double vision. And it's more common in women. It affects usually younger patients. And in 1835, Graves gave the classic description of the disease. This is the physician. And it's also called as Basedow-Graves disease. Usually we call it as Graves disease. So these are some of the signs we see with respect to the Graves disease. So this is the eye symptoms which we discussed. They can have splitting of the nails, longitudinal splitting of the nails, and this is seen in this picture. And they also have edema of the it's actually the legs, we call it the shins, or we call it actually pretibial mixed edema. This is in severe cases you can see this. Graves' ophthalmopathy. A lot of times we do talk about this because this is very specific to this condition. Sometimes you see patients who initially come in only with eye signs. They don't have any other symptoms. They have just a protrusion of the eyes, and then they go to their physician, and then the physicians do their thyroid function tests or thyroid blood tests, and lo and behold, they'll have Graves' disease, or the thyroid levels will be high. In that case, the TSH will be low and the free T4 will be high, and they'll say, okay, you have hyperthyroidism due to Graves, and you may have to see either an endocrinologist or the physicians themselves take care of it. In Graves' ophthalmopathy, this happens because of the inflammation and other immune system events which affect the muscles around the eye. So why does it happen? The immune system proteins which are secreted, or antibodies which are secreted for the thyroid or against the thyroid, they have the same sort of molecular basis with respect to the soft tissues which are surrounding the eyes. So when these antibodies are secreted against the thyroid, they also affect the muscles around the eye or the soft tissues around the eye. So that's why the inflammation happens around the eyes. And why it happens only in 30% of the patients, not the other 70%, no one really knows. So we just have to treat them accordingly and go from there. The resulting signs and symptoms may include bulging eyes, which is called as exophthalmos, gritty sensation in the eyes, pressure or pain in the eyes, puffy or retracted eyelids, reddened or inflamed eyes. It can also cause light sensitivity, double vision, and vision loss. So this picture I'm showing you again, as I said, these two patients have quite a bit of Graves' ophthalmopathy. One of the things is these puffy eyelids here you see, and the reddening of the eyes. So the second condition is called the toxic multinodular goiter, and this is usually where you see the thyroid gland is enlarged, or we call it a goiter, and multiple nodules in the gland produce excessive thyroid hormone here. And they may have, most patients are above 50 years, and they may have had the goiter for a number of years before it becomes overactive. So they won't know that they're becoming overactive until they start having symptoms. That can be an issue because they've had the goiter for a long period of time, and until and unless they start having symptoms, then they may see the physician. And again, the blood tests are pretty much the same. It's nothing different, which we discussed earlier. All these are goiters, and again, difficult to say if these patients have symptoms or not. If they are over-secreting their thyroid hormone, then they have a toxic multinodular goiter. Toxic nodule, this is just one single nodule. It may be just, you may not even be able to feel it or see it. That can also cause hyperthyroidism by producing excess thyroid hormone. And the blood test will be the same, the TSH will be low, the free T4 will be high, but sometimes if you are able to feel it, then we may get an ultrasound also just to see, and then if you are doing a radioactive uptake and scan, it shows that maybe only one part of the thyroid gland is taking more iodine compared to the other part, and then we may say it as a toxic nodule. So the next condition is called subacute thyroiditis. The thyroid gland in this situation is usually painful, and you may have to take painkillers or even steroids to sort of calm the pain down or to ease the pain. And basically because it's like the thyroid itself catching a cold. That's usually the term I use to describe it to the patients. Basically what happens is it's an inflammation, and because the thyroid is actually not producing more hormone, but whatever hormone is produced and stored, it dumps it into the bloodstream. So it is actually a sick thyroid gland. It can produce more, but whatever hormone is produced and stored, it just dumps it in the bloodstream all at once. It's not regulated, so it just dumps everything, and large amounts of thyroid hormones are released. It usually resolves spontaneously. You just have to wait. Initially, the symptoms may be very sort of disturbing to the patient or disabling to the patient. You have to explain to them and say, okay, look, this is what probably it is. We just may have to wait. And heals over several months, and sometimes can actually result in hypothyroidism. As I said, if the inflammation happens and it destroys the thyroid gland, it may not recover. And if it doesn't recover, then you may go into the hypothyroid range, And if you go into the hypothyroid range, obviously you have to treat the hypothyroidism. So follow-up is just blood tests and then go from there. And the initial part, you may have to do painkillers like ibuprofen, and we may have to also give steroids. So postpartum thyroiditis, usually this happens after delivery. It's 5 to 10% of the pregnant women, and most women recover from it. So again, blood tests and follow-up is very important. In some cases, it can result in hypothyroidism and requires lifelong thyroid replacement. But in postpartum thyroiditis, usually it's not painful. Okay, and the next one also in silent thyroiditis, similar to the postpartum thyroiditis, but not related to pregnancy, and the thyroid is not painful. Excessive iodine ingestion. So some of the medications and also what our over-the-counter medications we have a lot of iodine. One of them is the kelp tablets. Some take it as a health food reason, things like that. Some cough medicines also have some iodine in it. Heart medications like amiodarone. Okay, this is usually given for irregular heartbeat. We call it as atrial fibrillation. We give amiodarone. So that has almost like 30% of it is iodine in it. And IV contrast agents, if someone is going for a CT scan, they are given IV contrast. The IV contrast is nothing but iodine in it. So for all these conditions, your thyroid should be in a state where it can absorb the iodine and start producing a lot of thyroid hormone. If it's not, then it won't do anything. But if it is, and it starts producing a lot more thyroid hormone by taking up the iodine, then it can cause hyperthyroidism. Again, I would say majority of the patients who are taking these, they should not have any problem, but some patients can do, because depending upon which state your thyroid is in. The other important cause is over-medication in patients who have hypothyroidism. So they have hypothyroidism, we are giving them medications, and then for some reason, okay, either they lose weight or the physician prescribed them a little more than usual, then it can cause hyperthyroidism by itself. So need to check the hormone levels when stable at least every 6 months to 1 year, and if they're not stable, maybe even every 3 to 4 months until they're stable. So the treatment of hyperthyroidism, medications is usually the first choice. We have methimazole and also PTU. These are the two most common medications. The first one is the methimazole. That's what I use at least in 90% of my patients. PTU is another one usually used in patients who are pregnant and also hyperthyroid, or if they're allergic to methimazole. Side effects includes rash, rarely liver function abnormalities, and also as an allergic reaction, it can decrease your white cell count. WCC, I said white cell count. What happens in how the patients present in that situation is, we tell them, okay, previous night you went to bed, you were fine. Next morning you got up, you got the worst sore throat in your life. Then you need to stop the medication and call us. So, and if it happens, it usually happens in the first, I would say, few months of the treatment. I've seen maybe 3 cases in my 13 years. It's not that common, but it can happen. But if it happens, the patient will know that it's something is wrong with them. So, but it is better to mention it to them, because you don't want them to take the medication for another 2 or 3 days more, and their white cell count is pretty much undetectable and they end up in the hospital with some infection. And usually you need to be on these medications for 1 to 2 years, and sometimes longer, and even maybe lifelong. So the way I tell my patients is, you probably will have to be for a couple of years. At the end of 2 years, if you're able to take you off the medication, we will. But if the lab test does not give us any idea that we are able to take you off, then you probably need to be on it for lifelong. Beta blockers, these are medications which are used for basically controlling your heart rate and the symptoms. It is a blood pressure medication, it's a medication which protects against having heart attacks, so on and so forth, but they're also used in hyperthyroidism, because basically to decrease the symptoms when patients are definitely having the symptoms of hyperthyroidism like palpitations, increased sweating, and other things. So the next treatment is the radioactive iodine treatment. Early on we talk about the diagnosis with radioactive iodine. In this we are treating with radioactive iodine, and the compound which we are using here is the iodine 131, not the iodine 123. The iodine 123 we use for more diagnosis, iodine 131 is more used for treatment. And dose is determined by the activity and the size of the thyroid gland. And most of the times they say up to 15 millicuries is enough, but that is again decided by the physician. Usually I would say sometimes you may need more also, because we don't want the patient to come back for a second dose of radioactive iodine after 6 months or a year. So you want to treat them once and for all, and most likely they will become hypothyroid and they have to be on medication for the rest of their life. Again, when you're treating with radioactive iodine, you have to use beta blockers because you're basically destroying the thyroid gland, and a lot of thyroid hormone is going to be released into your bloodstream. So that's what happens. So you have to use beta blockers to decrease the symptoms. So surgical removal of thyroid gland, this is usually the last resort if the first and the second one we are not able to treat the patient. Usually we'll need medication treatment, that's methimazole or PTU, before the surgery is done. And as I said, both for radioactive iodine and surgery, patient will need thyroid replacement for rest of their life. So subclinical hyperthyroidism, as I said, more patients have subclinical hyperthyroidism than have overt hyperthyroidism. You saw 0.7% had subclinical and 0.5% had overt. So this is a condition where the TSH is lower than 0.4, but the T4 and T3 are normal and patients do not have any symptoms. They don't have symptoms. They may get a TSH for whatever reason, and then we'll probably do the T4 and the T3, and when we ask them what symptoms you have, they'll say, no, I don't have any symptoms. So this is subclinical hyperthyroidism. Patients are treated if they're above 65 and the TSH is less than 1, and with cardiac risk factors. If they have any cardiac risk factors, we don't want the excessive thyroid hormone to sort of exacerbate it, with heart disease or osteoporosis. Other patients can be safely observed with periodic blood tests, and also if their symptoms develop or not, depending upon if they don't develop, they can see their physician more like every 6 months or 1 year. If they develop, maybe 3 or 4 months, and then they can get the blood tests. So hyperthyroidism and pregnancy, it's about 2 per 1,000 pregnancies, and usually worse in the first trimester and improves in the second and third trimester. So you have to be very careful. Reason is because it gets worse in the first trimester and improves in the second and third trimester. So you have to follow these patients very closely. Usually diagnosed by blood tests, cannot use radioactive iodine because the patient is pregnant or the woman is pregnant. Medications is usually the choice. In the first 12 weeks we use PTU, which is the propylthiouracil, and the 13 weeks onward we use methimazole. So that's usually what the FDA also tells us, the American Thyroid Association tells us. Blood work every 5 to 6 weeks you have to do it, and patient labs are slightly kept in the upper limit of normal. The reason for that is you don't want to cause hypothyroidism in the baby. That can be really dangerous to the baby's development of the brain and so on and so forth. We try to keep them slightly hyperthyroid itself. So what we have to do is, after the first trimester, we have to cut down the medications and tell them why we are doing it and follow the labs more closely. So the next topic is hypothyroidism. So hypothyroidism is the underactivity of the thyroid gland, which happens when the thyroid gland produces less than normal amount of thyroid hormones. Slowing down of bodily functions, we'll talk about the symptoms a little bit later. Most of the times it's permanent, and sometimes it can be temporary. I think we have seen in hyperthyroidism itself, there are some conditions where it can be temporary. Some studies have shown up to 10% of women and 3% of men are hypothyroid. And initially what happens is the thyroid gland does secrete more hormone to compensate, but it is not able to keep up. So then it basically says, I can't secrete anymore, and then you'll have the lab abnormalities, and then patients also usually by that time have some symptoms. Some of the symptoms are fatigue. Again, I sort of underlined it and bolded it. Please note, fatigue has many causes, and thyroid is one of them. A lot of patients do come to physicians and say, okay, I'm fatigued, can you see if it is my thyroid? Yes, that's definitely a valid reason to come and see the physician, but a lot of times it's not. That's what I want to tell you. Hypothyroidism is one of the many conditions which can cause fatigue. Drowsiness, forgetfulness, difficulty with learning in kids, dry and brittle hair and dry and itchy skin, puffy face, constipation, sore muscles. Weight gain again has many causes, and fluid retention. Heavy irregular menstrual periods, you will have bleeding in between the periods too. So that's the very important one of the symptoms which women in the menstrual age group have. Increased frequencies of miscarriages and increased sensitivity to many medications. Intolerance to cold, receding hairline, hair loss is one of it, facial and eyelid edema, dull blank expression, they may not have any expression on their face, extreme fatigue, thick tongue, and this is usually thick tongue is later on in the disease. It's not like when you're, it's very mild or anything like that. Anorexia and brittle hair, nails and hair, and menstrual disturbances which we discussed. Hair loss, lethargy, dry skin, muscle aches and weakness, constipation we discussed, and late clinical signs and manifestations, they can get admitted to the hospital also with this. Subnormal temperature, usually it's okay, 97 to 98 is the normal. These patients will have 92, 93, 94, and they definitely probably will at that time get admitted to the hospital. Bradycardia, which is very low heart rate in the 40s, 50s, weight gain, loss of consciousness, thickened skin, and sometimes cardiac complications which include, we call it fluid around the heart, we call it pericardial effusion. So that also can happen. So causes of hypothyroidism, autoimmune thyroiditis. This is the most common cause. We also call it as Hashimoto's thyroiditis. Immune reaction, it's an immune reaction, basically happens in the person's own body, and some kind of an event triggers it, results in the enlargement of the thyroid, which can be a goiter, and autoimmune conditions. Other autoimmune conditions can be associated with it, and it can run also in families. After radioactive iodine treatment or surgery, which we discussed, if the patient have radioactive iodine or if they have surgical removal of thyroid, obviously that can cause hypothyroidism and you'll need to be on replacement. Spontaneous for no apparent reason. Now, we may not find a reason even if we try to do the blood tests and so on and so forth. Medications, again, high doses of iodine can cause both hypo or hyper. Again, as I said, it depends upon the state of your thyroid gland. Sometimes it can cause hyper, sometimes it can cause hypo. The amiodarone is also the same. As we discussed, this is a heart medication which can cause the same, both hypo and hyper. And lithium, which is an antipsychotic medication that can also cause hypothyroidism. Usually when you're using amiodarone and lithium, you have to check your thyroid functions before you start the medication and also periodically thereafter. And the physicians pretty much know about this, and that's what they do when they're starting these medications. Subacute thyroiditis, this again we discussed earlier, is a painful inflammation of the thyroid. The cause is usually not known. Sometimes it can be upper respiratory tract infection, may cause hyperthyroidism, which is usually temporary and can lead to permanent hypothyroidism. Postpartum thyroiditis, which is pretty much similar to that, except that it is not painful and it's after pregnancy, and it usually comes back into the normal range but can cause hypothyroidism. And congenital hypothyroidism, infant is born with the inadequate thyroid tissue or an enzyme defect which does not allow to make the active thyroid hormones. If it's not treated in adequately and also in adequate time, it can cause physical stunting and mental damage also. So it usually happens like 1 in every 3,000 to 4,000 babies can have this diagnosis. It's very rare now because for the reason it is it's pretty much illegal to send a patient or the infant born in US without getting the thyroid hormone checked. They have to check it. So they check it within the 24 to 48 hours initially, and if it is abnormal, it is also illegal for them not to get their thyroid hormone checked within the first 30 days. So they'll have to repeat it again. So for that reason, even if someone has a defect, it will be picked up and they will make sure that their primary care, the pediatrician follows up on it and go from there. The other cause is the pituitary hypothyroidism. This is again, as we discussed earlier, the pituitary gland produces the TSH and that sends signals to the thyroid gland to produce the T4 and T3. So if the pituitary is not there at all, or the pituitary is destroyed for whatever reason, that doesn't allow the TSH to send signals to the thyroid gland. So it's a rare cause of hypothyroidism. Can be radiation, can be pituitary surgery. So you have to treat them with thyroid replacement. So the blood test, again, as I discussed, TSH is the screening test. Usually if it's hyper or hypo, it does not matter. TSH is the screening test for the thyroid conditions. Free T4 and free T3 are confirmatory tests. They're usually low, and the TSH here in this case is high. So if you have hypothyroidism, which is low thyroid, your TSH is high, and your active thyroid hormones T4 and T3 are low. If you have hyperthyroidism, where you have excess thyroid hormone, your TSH is low and your T4 and T3 are high. So no scans required. This again, going back to the HPT axis in hypothyroidism, basically you don't have enough T4 or T3 in your bloodstream and the thyroid is not able to produce it. So the negative feedback loop to the pituitary gland is not significant. So the TSH, the pituitary gland keeps producing more TSH and telling the thyroid gland to secrete more thyroid hormone. But unfortunately, the thyroid gland is not in a state to secrete the hormone. So the TSH keeps increasing unless you get treated or the person is treated. And I want to show you one other thing here. The secondary hypothyroidism, we call this is actually this condition. The pituitary hypothyroidism is also called as secondary hypothyroidism, and all the other causes of the hypothyroidism is called as primary. Why we call it secondary is because the TSH here is low because the pituitary gland is destroyed and it can't produce any TSH, and your thyroid gland in turn can't produce anything either. So that's why it's called as secondary hypothyroidism, and both are low here. So you have to just go with only the T4 levels in this condition. You can't look at TSH here. Sometimes that does happen. We may think, okay, a patient has hyperthyroidism, but they'll have symptoms of hypothyroidism because they're giving you all the symptoms of hypothyroidism. Then we check your TSH, the TSH will be low. So then we can't figure out. Then we ask them, okay, do you have any surgeries in the past? Have you had a head injuries? Even head injuries can cause it. So then they may say, okay, no, maybe no surgeries, maybe a head injury or not. Then we'll have to look at the T4 and T3. If the T4 and T3 are also low, then we come to the conclusion they probably have a secondary hypothyroidism. So severity of the primary hypothyroidism by thyroid levels. This is the graph I wanted to show you. So if you look at it here, TSH is this graph here. If you look at it, it starts going up. Okay, much earlier. It rises fast and abruptly much earlier than the T4 and T3. The T4 and T3 become lower much later than the TSH. If you look at it, when the T4 becomes low, the TSH is already high. So that's why TSH is the screening test, and based on the TSH you can definitely get a free T4, and patients usually have symptoms by the time the TSH is high. And the T3, if you look at it, it is even later. The T3 decreases even later than T4 by the time the TSH is pretty high. So treatment of hypothyroidism is treated with levothyroxine, which is the generic medication, and Synthroid or Levoxyl, which are brand names. Usually the dose of the medication is based on the weight of the patient. Sometimes you can start on a smaller dose if the TSH values are not that significant. You can start at a smaller dose and increase it. But in some cases like the elderly or patients with cardiac issues, we start at the lower dose and titrate up. In most cases, patients ask me, means as soon as we tell them, okay, you probably have to take levothyroxine, the first question they ask me is, when can I stop it? So usually the most treatment is for life, okay? Yeah, if there is an option to stop it, we can try and see, but usually we'll have to do it over a few months. Once the patient is stable with their TSH, then we can decrease it and see if it allows us to stop it. Periodic monitoring of TSH is needed for optimal treatment. And the thyroid tablets, it comes to 11 to 12 different strengths based on the manufacturer. I think Synthroid has 12 different strengths and Levoxyl has 11 different strengths. And also generic levothyroxine has 11 different strengths. Again, so when do you take your thyroid medication? This is very important, I would say. You should be taken on an empty stomach at least 60 minutes before eating. If some patients ask me, is 30 or 45 minutes okay? It's probably okay, but usually according to the manufacturer, at least 60 minutes they say. Best time to take it in the morning before eating. Maybe if you ask me the second best time, before going to bed, but you have to pay attention when your last meal was. So if someone is going to bed at 10 o'clock and they eat at 9 o'clock, probably not a good idea. If someone is going to bed at maybe 9 o'clock, then they eat at 6 o'clock, that's okay. So 3 hours after the last meal. If calcium or iron also is being used, then 4 hours of separation is needed. But again, this is not, this bullet point is not validated, but usually that's what the American Thyroid Association and other physicians say, but sometimes it may be difficult. The next main bullet point also I want you to pay attention to is thyroid medication is a narrow therapeutic index medication like Coumadin. I don't know if any one of you take Coumadin here. Coumadin is a blood thinning medication. Yeah, so that is a narrow therapeutic index medication. Same way the thyroid hormone is also a narrow therapeutic index medication. So what do we mean by that? Small changes in dose can significantly change the levels in labs, and also the patients can develop hypo or hyper symptoms if we decrease or increase the dose, even with small changes in dose. So I usually tell patients the dose changes have to be very incremental, small increments you have to make it. You don't want to change someone from like 50 micrograms to 125 micrograms. So there are a lot of doses in between. From 50 you have 75, then you have 88, then you have 100, 112, 125. So you want to increase slowly. You may have to go through a couple of steps, but that's the right way to do it. FDA says both brand name and generic thyroid medications are the same, but as an endocrinologist and when I talk to my other colleagues, we may have a different view about that. That's again my personal opinion. Okay, the reason is, I've again bolded it, the reason is generic levothyroxine can be anywhere between 95 to 105% of the given dose. So I'll explain to you in a bit. As per the post-market drug safety information of FDA in 2015. So what I mean by that is, let's say someone is getting a generic levothyroxine dose of 100 micrograms. So according to the FDA, they've given it the generic manufacturers, you can either give them 95 micrograms or 105 micrograms. The pharmacy doesn't know that. I don't know that. The patient doesn't know that. It depends upon what batch was manufactured by this manufacturer. Okay, they may know that, but they don't send it to the pharmacy, or the pharmacy doesn't know that. So you may be getting 100. I am writing 100 micrograms prescription for the patient, but he may be getting 95 in January prescription, and he may be getting 105 the next prescription. So there's almost like the 10% variation in that. So we don't know that. So that's why some endocrinologists or a lot of endocrinologists feel that you want to stick to brand name, but again, brand names are expensive. I do get patients when they come and tell me, can I increase my thyroid medication even though my thyroid levels are normal? Okay, well, yeah, these are patients who are being treated for hypothyroidism, and you are on the right dose of medication, your TSH is normal, your free T4 is normal. Can I increase it a little bit more? It's not an effective weight loss drug. It has been sort of shown in studies, and it may increase the metabolism to some extent, but it also increases the appetite. So for that reason, I would say these are the number of patients. Some of them were placed on T3 and some of them placed on T4, and they were followed up, some of them as much as almost like 6 months. And if you look at it, here is the weight loss. If you're more towards the left when you're facing the screen, then you're better. But most patients didn't lose any weight, but the calorie intake did go higher. So it's not an effective weight loss medication. I tell my patients, okay, I'm okay, I will increase it, but as long as your lab tests are normal. If your lab tests start showing that you're hypothyroid, then no, we are not going to change the dosage. We'll actually have to decrease the dosage. So these are the two thyroid medications. The one on the left is the Synthroid. Synthroid has an additional like 300 milligrams dose here, and the Levoxyl is the maximum dose is 200 milligrams. These are the brand name manufacturers. So the color is actually pretty much the same. Each dose comes in a specific color, and they're pretty much the same for both the medications, and even the generic levothyroxine. Most endocrinologists do not use Cytomel. So what is Cytomel? It's the T3, which is the active thyroid hormone T3. Some patients may want to use it. I sometimes do oblige for it. Again, I tell them as long as your thyroid levels are in the normal range. There's no strong evidence to support the use. In some patients, when you use, has to be taken twice a day. Use of Armour thyroid, which is a combination of T4 and T3, and Nature thyroid is also a combination of T4 and T3. That again, FDA had to approve these medications because they were already in use when FDA started approving it. So it is not, if you ask me, is it FDA approved? I have to say yes, because these medications were already being used when FDA first came into existence. So for that reason, I personally have problems controlling the symptoms of the patient in correlation with their labs with these medications. But if someone is taking it and they say that's the only medication they want to take, I do oblige, as long as their labs are in control. The problem with this is the T4 and T3 combination you get is 3:1 or 4:1. That's usually they're combined in that proportions. And the normal means the ratio of T4 to T3 in human beings is like a 9 or 10:1. So that's the problem. So hypothyroidism and pregnancy, it's not very clear if all women planning for pregnancy need to be tested for thyroid disease. If you have a family history, if you have a high-risk patients or patients with previous hypothyroid symptoms, things like that definitely need to be tested. If they're already hypothyroid, needs to be tested as soon as she is pregnant and 4 to 5 weeks thereafter. Usually in the first trimester, you want to check every 4 weeks, and after that maybe 5 to 6 weeks. And dose needs to be adjusted based on the tests. Usually we tell the menstrual age group patients who are planning for pregnancy, the American Thyroid Association says if you're planning for pregnancy and you're hypothyroid, let's say someone is taking 75 micrograms, 1 tablet once daily. So as soon as you become pregnant, before that you were taking 7 tablets a week. As soon as you become pregnant, you have to take 9 tablets a week. So they tell them to increase it by 2 tablets. Even without informing the physician, you can do that. If it is not treated during pregnancy, it can lead to anemia, premature birth, miscarriage can also occur. And one important thing is after delivery, doses needs to be readjusted to make sure the patients are not over-treated, because we are increasing the dose during pregnancy. You don't want to leave them on the same dose after delivery, because then they become over-treated and they can have hyperthyroid symptoms. So thyroid nodules. So this again is a slide I showed earlier. It is located between the collarbones and also the front of the neck below the Adam's apple. Thyroid nodules occur in 5% of women and 1% of men. It increases with age. When a nodule is found, one thing we need to rule out is cancer. Again, it's not very alarming because 95 to 97% are not cancerous. So most of these nodules are benign. Usually patients do not have any symptoms. It can be found on a routine exam when they go for a physical, or sometimes when you do an ultrasound for the neck arteries, like the carotid ultrasound, or MRI or CT of, let's say, maybe the neck or the chest, or sometimes on a PET scan. So the nodules can be simple overgrowth of thyroid tissue itself. They can be fluid-filled cysts. They can be inflammation, which is we discussed as thyroiditis earlier, or tumor, which is benign or cancerous. Most nodules previously were surgically removed until 1980. If you had a nodule before 1980, they would have taken it out, but not anymore. Most of them can be observed over time and can be referred for surgery to surgery or surgeon if needed. So the problem is it's not possible just to find out a nodule is cancerous by physical exam. So you have to have the ultrasound of the thyroid, and sometimes the thyroid fine needle biopsy or aspiration we call it FNA, with or without the ultrasound, and sometimes you need a radioactive iodine scan also. And thyroid blood test is also done to see which way we have to go. I have a schematic representation a few slides later. I will show you that. The thyroid ultrasound, the sound waves are passed through the skin and the image is obtained. Some characteristics help to see if a biopsy is needed. Again, as I said, I'll be showing you what are the characteristics. And ultrasound can be used if the needle has to be placed during the biopsy. So most of the time the biopsies are done with the ultrasound nowadays. And we also use the ultrasound to follow up in 6, 12 or 24 months and we ask patients to come back once if the nodule has been biopsied and it is benign, it's not cancerous, we say, okay, come back and see us in 12 months or 24 months based on the biopsy. And the radioactive scan again is needed if the TSH is suppressed and the patient has hyperthyroid symptoms. So this is the thyroid ultrasound. That's the thyroid ultrasound probe. Basically, they'll place it on your neck, they'll apply some gel, and they'll look at the sound waves which are passed, and it comes up as is on the screen, and what are the characteristics of the nodule. Okay, what are the symptoms? Again, most of the times no symptoms. Difficulty in swallowing, that can be one of the symptoms. Difficulty in breathing, and sometimes can cause hoarseness of the voice if pressing on the nerve which supplies the voice box. And so obviously cosmetic appearance can also be an issue. This is the schematic representation. So the thyroid nodule found clinically or incidentally on imaging, first what you need to do is get the TSH and also the thyroid ultrasound. So let's go this side with respect to if the TSH is low. So then we get the radionuclide scan or the radioactive iodine scan. So if we know the nodule is functioning, that means it's secreting more thyroid hormone than it should. Then we check the T4 and T3. So if the T4 and T3 are normal, then the patient has subclinical hyperthyroidism, which we already looked at. Most patients we have to observe over time, observe in most cases. And if the patients have overt hyperthyroidism and the T4 and T3 are high, then you need to treat it. So if the TSH and thyroid ultrasound, the TSH is normal or elevated, so then you need to find out whether the nodules meet the criteria for FNA. FNA is fine needle aspiration, so then you need to send them back to the radiologist or some endocrinologist do them in their office to get the FNA. So you do the FNA and then see if it is non-cancerous, you just follow up. If it's cancerous, obviously you need to refer to the surgeon. If the radionuclide scan is done and it's non-functional, then you just go ahead with, we call it a cold nodule, then we go ahead with the FNA. So it's a little bit complex, but this is how we usually treat. So the first will be TSH and the ultrasound, and then you branch out into whether the TSH is low or the TSH is normal or high and go from there. So this is a picture of the FNA of the thyroid nodule under ultrasound. So there is the ultrasound probe here, plus there is a syringe and a needle here. It's slightly uncomfortable. I don't think it will be really painful, but again I would say probably depending upon the pain tolerance of the patient. You are given some local anesthetic, okay? They don't give you any IV sedation or anything like that because the procedure is pretty much done in 20 minutes, 20 to 30 minutes I would say. And then they basically get some cells out from the nodule and they look at under the microscope and then they go from there. So once you do the ultrasound, basically depends on what are the nodules which you need to biopsy. You can't biopsy every single nodule. That's not the way to do it. So if you have high suspicion of the nodules, it's almost 70 to 90% that they may be cancerous. So these are the nodules we need to pick up. These are with microcalcifications. These are hypoechoic with irregular margins, hypoechoic where the nodule is more taller than wide, and again hypoechoic with encapsulated nodule here. So all these are with high suspicion. There are ones with intermediate suspicion, ones with low suspicion. So if you have low suspicion or very low suspicion, you don't need to biopsy them. If you have intermediate or high suspicion, more than likely you want to biopsy. So this is again a schematic representation. Once you do it, if you get a non-diagnostic, you go to your physician, he orders the biopsy, and then later on you come back and talk to him, he'll say, sorry, oh, it was a non-diagnostic. That can happen in about 10 to 15% or even 20% of the patients. Even though they do the biopsy or the FNA, they are not able to get enough cells. And then what we need to do is repeat the biopsy with another ultrasound in maybe 6 weeks or 8 weeks or 3 months. If it shows that it is papillary cancer, thyroid cancer, you have to go for thyroid surgery or thyroidectomy. If it is suspicious, sometimes they may say it's suspicious for malignancy, or we say it can be a follicular lesion or a follicular adenoma. So I'll go into the types of thyroid cancer because sometimes you cannot differentiate between a follicular adenoma versus a follicular cancer. So they may say suspicious, then you may have to have, more than likely have to have thyroidectomy. And if it's a benign nodule, you just follow these patients, as I said, every 12 to 24 months. But when you're following, if the thyroid nodule increases in size by 20% in 2 to 3 different directions, so again the thyroid nodule is a 3-dimensional figure, so in 2 to 3 different directions it has to increase by 20%, then we may say we may have to rebiopsy the patient. And then rebiopsy, if it comes back as cancerous, again they'll have to go for surgery. If it doesn't, then just follow up. I won't go into all these details here. There are some other things which we go look at there and do some other genetic analysis, so on and so forth, with the thyroid biopsy itself. So the thyroid nodule treatment, no medical treatment is there unfortunately for thyroid nodules. We can't give any medications and make the thyroid nodules go away. If causing compression symptoms, surgery is the option. Previously, we used to use levothyroxine, that's just the thyroid hormone which we treat hypothyroidism patients, to shrink it. So what levothyroxine would do is, as long as you're giving the medication, it would slightly shrink it by maybe 10, 15, 20%. But it also used to cause irregular heartbeat and also increased risk for osteoporosis. So we stopped doing that almost actually maybe 20 years ago. So we don't do that anymore. So if it's benign, we follow every 6, 12 or 24 months depending upon the nodule characteristics. If there is a change in size or characteristics or new nodules develop, we have to repeat FNA as I discussed earlier. So the last part of my talk is thyroid cancer. So the chance of being diagnosed with thyroid cancer has increased 3-fold in the last 30 years. This is not because the incidence itself is increasing, it's just because we're using the thyroid ultrasound more often and also detection of more smaller cancers. Usually younger age than most of the adult cancers like prostate, colon cancer, things like that. It's patients who get thyroid cancer are younger age group. 3 out of 4 cases are women. Women are usually in the 40s and 50s and men in the 60s and 70s. Death rate has been studied for many years, and I tell my patients who come to see me with thyroid cancer, again, thyroid cancer is one of the cancers which is treated by endocrinologists. They're not treated by oncologists, okay? Unless you have the thyroid cancer is spread to other parts of the body, then the oncologists get involved. But still endocrinologists are the physicians who usually treat thyroid cancers. And as I was trying to say, I usually tell my patients who get thyroid cancer, you probably won't die of thyroid cancer, you more than likely will die of old age. Okay, so that's usually the case because it's very rare to die of thyroid cancer. And most of the time we can treat it fairly easily, and patients usually lead a long life. It can be hereditary in case of medullary thyroid cancer, which is one of the types of thyroid cancer. So having a first-degree relative like a parent, brother, sister or child with thyroid cancer increases the risk. So if someone has a nodule whose parent or sibling had thyroid cancer, it's definitely good to pursue that nodule. Even though you may say the characteristics may not be that in the high risk category or anything, even then it's better to pursue the thyroid nodule. Diet low in iodine can risk for both follicular and papillary cancer. These are 2 different kinds of cancers. If someone is taking low iodine diet, that can. But again, having said that, in United States, the diet is replete. That is, we have sufficient iodine. We don't need more iodine than what we are already getting. We don't need to add iodine into or take iodine tablets and things like that. Unless people are on a very low iodine diet, then you are at a risk. Again, radiation is a proven risk factor. We don't see that often here. Head and neck radiation in childhood, if someone has leukemia or lymphoma and you get head and neck radiation, that can be a risk for thyroid cancer. And before 1960s, radiation was used as a treatment for acne, fungal infections, ringworm, etc. So these can be a risk for patients who have used radiation for those reasons. And again, radioactive fallout in case of Chernobyl in Russia and the recent with respect to the incident in Japan and so on and so forth. So thyroid cancers and signs and symptoms. Usually is a lump in the neck, sometimes growing quickly, swelling in the neck, pain in front of the neck, sometimes going up to the ears, hoarseness or voice changes that do not go away, trouble swallowing, trouble breathing, and constant cough that's not a cold. So trouble swallowing and trouble breathing, thyroid is situated in your front of your neck. So if you have trouble swallowing, usually you have to press the larynx, which is the trachea, which is even before the gullet, which is the esophagus. So if you have trouble swallowing, more than likely you will have trouble breathing also, but these usually are late symptoms. How do you diagnose and what are the types? Again, as we discuss, ultrasound and biopsy is the way to go with the thyroid nodule and for diagnosing thyroid cancer. Types of thyroid cancer include papillary thyroid cancer, which is the most common. It's about almost 70 to 80%. Follicular thyroid cancer, which is about maybe 20%. Hurther cell cancer is not that common, but it's one of the things where all you need is surgery and you don't need anything more. Medullary thyroid cancer, this can run in families, okay, and most times medullary thyroid cancer is treated by oncologists. And anaplastic thyroid cancer, this is the cancer which has poor outcomes. I've seen only one case of anaplastic cancer in my 13 years experience. Medullary cancer is also very rare. I've seen about 3 or 4 cases in my 13 years. Radioactive scan and treatment used usually after the surgery to diagnose any residual disease, because see, thyroid gland is the only gland which can take up iodine. So that's why we keep coming back to this radioactive iodine. So if we take any iodine, the only thing, either you will excrete it in your urine and also stools, or it is taken up by your thyroid gland. When we are looking at after surgery, so how are we going to look at? One of the ways to look at is by a radioactive scan, because if you've already had surgery, most of your thyroid or all your thyroid has been removed. So if you give radioactive iodine medication or a tablet, if still there is some uptake in your thyroid gland area, that means still you have some thyroid gland left there, or that may be cancerous, or cancer cells also may be there. So it can be used to find out if there is any residual thyroid is there, and also it may need to be used for treatment. PET scan is used if the cancer does not take up iodine and to find out if the cancer has spread. So these are some of the histology slides. I just put it up there. We use this Bethesda classification to classify them. This is the most common type of thyroid cancer, which is the papillary thyroid cancer. This is the second most, which is the follicular thyroid cancer, and the medullary one, which runs in families. Before 2009, we used to treat a lot of patients who have thyroid cancer with follow-up radioactive iodine. We don't do that anymore. 2009, the guidelines changed, and again 2016, the guidelines again changed, because for the reason they were finding that most patients with thyroid cancer were getting the radioactive iodine, and some of them were getting higher dose of radioactive iodine. So we have risk scores here: low risk, intermediate, and high. We go based on this. If their patients are in the intermediate and high risk, they get radioactive iodine. If they are not in the intermediate or high risk, if they are in the low risk, they don't get a radioactive iodine anymore. We follow them with thyroglobulin, which is a protein which is produced by the thyroid gland, and thyroglobulin antibodies. They are used and monitor the patients after surgery and also radiation or radioactive iodine. Calcitonin and CEA, these are the 2 other blood tests which are used in case of medullary cancer. They are special to medullary cancer. Treatment, the initial treatment is surgery for all types of thyroid cancer. After that, you have to do radioactive iodine if they fall into the intermediate or high risk group based on the American Thyroid Association guidelines. Preparation of radioactive iodine for diagnosis and treatment can be done 2 ways. Because see, what happens is, if you're already taking thyroid hormone because you've had recent surgery, and the thyroid, if there is any thyroid tissue still left there in the surgical area, so what we want to create an environment is that whatever thyroid is left there, we want it to take up iodine. So there are 2 ways to prepare the patient. One of them is by asking them not to take their thyroid medication for 2 to 3 weeks or even a little longer. So, but they may feel very awful during that time, but that's the way to do it. The other option is we can give a medication called Thyrogen. It's 2 injections. Basically, it's artificially creating the environment where the body feels it needs iodine. So there are 2 ways. Nowadays, we use this Thyrogen more often. Again, it's based on the insurance of the patient and so on and so forth. All patients need to be on thyroid replacement once they have surgery, and depending upon the risk of the patient, the dose is adjusted based on their thyroid stimulating hormone. And we also do neck ultrasounds periodically to see if there is any recurrence of the thyroid cancer.
Well, that concludes our program for the evening. Thank you
Okay,
very
thank you.
much.